Good evening to all. On behalf of Mylan Pharmaceutical, I welcome all the participants who are attending today's session. It is really an honor to introduce the eminent speaker from Hyderabad, Dr. Srivenu Itha. Before I introduce him, I want to share today's topic. The topic is targeting Farnesoid X receptor with obetiholic acid, hype or hope. So, Dr. Srivenu is the current CEO he's a distinguished senior gastroenterologist and currently he is the CEO in Cygnus Institute of Gastroenterology, Hyderabad. He has received doctorate degree in gastroenterology from the hands of Honorary President APJ Abdul Kalam, and he has completed his fellowship in ERCB from Belgium and received award of the best scientific papers. Besides this, he has lot of other recognition he has got in various forums. Without wasting any further time, I request Dr. Srivenu to start the webinar. And before you start, I request all the attending participants that please put your questions for today's topic in the chat box. And Dr. Srivenu will give the answer for all your questions at the end of his lecture. Thank you very much. Over to Dr. Srivenu.
Thank you, Mr. Sushant Kumar, for that kind introduction. And also, I would like to thank all the participants who have come to attend this webinar, and also final thanks to Mylan company for really taking this a unique initiative and taking me as a speaker for this very important topic, which really it's people really looking forward for this drug and how its role in the liver diseases. So before I start, we all know that we are moving from conference meetings to webinars. So and we are all getting used to this new change. And at the same time, I request all of you to take care of yourself. This is a crisis time for the doctors. We cannot run away from the problem at the same time. We need to see the patient. So I only say just take care, stay safe, stay healthy, stay adequate precautions, and not to forget your health. And so now we'll move on to the present topic, which is on obetiholic acids, hope or hype or hope. And just a second. So today's topic is targeting Farnesoid X receptor with obetiholic acid, hype or hope. So my journey in the presentation is going to be like this. First, I'll talk about what is the role of Farnesoid X.
Dr. Srivenu, we are not able to see your presentation, doctor.
Oh, okay. Just a second. Let me Okay. Sorry.
Yes, come back to the browser, doctor. Yes. Now we are able to see.
Yeah. Let me begin.
Please open the presentation. Yes. Yeah. Put it to slideshow.
Okay now? Is it okay now?
Yes, doctor. And hide that tab at the bottom.
Yes. Hide. Okay.
Yeah, minimize the browser and open the PPT.
Is it okay now?
You can begin now.
Yeah. So now you can see the slides, right?
Yes, doctor. Yes, we are able to see the slides.
So today's topic is targeting Farnesoid X receptor with obetiholic acid, hype or hope. First, I'll talk about what is this Farnesoid X receptor. Then, what is obetiholic acid? What we know about it, because this is totally new drug to all of us, and how it has a role to play in primary biliary cholangitis and NASH, which we are really looking forward. Is it hype or hope? What are the data we have so far? And I'll give a summary based on that. Where does this drug really stand? So before I think going to the drug, let me talk what is this Farnesoid X receptor, because it's found to be a key metabolic regulator of systemic energy homeostasis. It is mainly expressed in various tissues, including liver, intestine, kidney, and adrenal gland, and to a lesser extent also in the adipose tissue and heart. It has a role on several biochemical pathways. It has a role in lipid metabolism, it has a role in bile acid metabolism, and it has a role in carbohydrate metabolism. So it has a role to play in diabetes, and it's a role to play in normal and pathological growth and differentiation, especially as an anti-fibrogenic factor. And also finally, it has a role to play in immunity also. So this drug, when compared to UDCA, which is only main predominant role is in the bile acid metabolism, but whereas even though it is closely related to UDCA, but there's several other metabolic regulator role in metabolic regulator pathways. So that's how it is really can be a key change as a wonderful drug, but how it is playing and what is the experience we have so far with this drug, we'll come to that in next few coming slides. So it has found to have some beneficial effects on various metabolic disease, including fatty liver disease, type 2 diabetes, dyslipidemia, and obesity. So based on the animal models, we found to have the farnesoid. We came to know several pathways with which FXR is related. And when it comes to fibrosis, it is found to have some anti-fibrogenic effect. This mainly through decreasing stellate cell activation, by increasing stellate cell apoptosis, by decreasing fibrogenesis to TGF-beta1 pathway, and also it has a role to play in increasing matrix degradation. With all these, I think it is found has an anti-fibrogenic effect. In addition, it also has anti-inflammatory effect, mainly by decreasing NF-kappa beta signaling pathway, and also is found to reduce the TNF alpha levels, IL-11 beta levels, IL-17 levels, and interferon gamma levels, and also found to be reducing IgM levels and CRP levels. This IgM levels has a definite protective role in the primary biliary cholangitis. And also it has some anti-atherosclerotic effect. Mainly this is through the increasing vasodilatation, and also decreasing endothelial inflammation, and also decreasing endothelial calcification, also shown to have effect in preventing the decreasing the smooth muscle cell migration. So all these has found to have definitely can have an effect on positive effect on preventing atherosclerosis. So when it comes to lipid metabolism, it is found to decrease the triglyceride synthesis. It is found to increase triglyceride clearance, and it is found to decrease VLDL formation, and also which can be negative effect is found to cause the decrease in HDL cholesterol levels, mainly through scavenger receptor beta-1 pathways, and also found to increase LDL cholesterol. But all of these were transient, which is found to get normalized over the time. In addition, I think which is a positive effect on glucose metabolism, so it can have a positive effect in diabetes mellitus. Mainly, it is found to increase insulin signaling. It is found to increase insulin sensitivity, and is found to increase insulin production, and it's same also said to decrease hepatic gluconeogenesis. So all these can be a contributory positive effect in improving the diabetes mellitus. And it has, not to forget, it has an important role in bile acid homeostasis like UDCA, wherein it is found to decrease bile acid synthesis, it is found to decrease bile acid uptake, it is found to increase bile acid secretion, and found to decrease the bile acid reabsorption. All these will have prevent in hepatocyte and liver injury by preventing the accumulation of the hydrophobic bile acids. This is like UDCA. But this FXR receptor, but it will have several other beneficial effects, unlike the UDCA. So that's where we are going to discuss how it really translates into the clinical benefits. So FXR agonism is favorable in liver regeneration, and also has a preventive in hepatocarcinogenesis, and also contribute to the extrahepatic effects like atherosclerosis and prevention of the renal diseases because of the other effects. So update on obetiholic acid. What do we know so far? What is this compound actually? So this is a first-in-class and selective Farnesoid X receptor agonist. It is a 6-alpha ethyl selective derivative from primary human bile acids, which is a naturally existing FXR receptor agonist, that is quinodeoxycholic acid. But compared to that, I think this stimulates Farnesoid X receptors 100 times more intensely than the CDA, and it is highly selective to the effector receptors with minimal activity to other bile acid receptor like G protein coupled bile acid receptor 1. And also it has anti-cholestatic and hepatoprotective properties, and it has been approved for use in primary biliary cholangitis and is found to be promising an option for NFLD and other liver disorders, so forth, with what are the existing data we have. So first I'll talk about the primary biliary cholangitis. A brief about the pathogenesis. It's an immune-mediated bile duct injury where there's an aggravation of bile duct injury by the hydrophobic bile acids. And it has a cholestasis with the retention of the there is a cholestasis with the retention of hydrophobic bile acids in the liver, resulting in the liver cell damage, apoptosis, necrosis, fibrosis, and eventually cirrhosis. And finally, the resulting in the liver failure as a cause of death. So, in the prior to this drug, in the UDC era, UDC is a wonderful drug as far as prevention of the progression of the primary biliary cholangitis, but it could not prevent the prevent transplantation in this PBC patient. If you look at this table, it's definitely had a positive role in retarding the progression of the disease. For example, 5-year survival in the patients, UDCA was 90% when compared to 79% untreated patients, whereas in up to 15 years, whereas you could see almost double the effect of UDCA compared to the non-treated group, but still it could remain unfulfilled as far as prevention of the disease. So we see how OCA fares in PBC patients. This is one of the first studies. It's the POISE study, which is published in NEGM way back in 2016, 4 years back. It's a wonderfully done study, which is a properly randomized study, where was 217 patients was chosen. They were divided to 3 groups in 1:1:1 fashion. Placebo was the first group, second group received 5 mg OCA, and third group received OCA. But after 12 months, they opened this study and made it open study. Even all the patients were given the option. Even the placebo patient received the OCA, depending upon whether some people they received 10 mg, and even the OCA 5 mg group, they were shifted to 10 mg, depending upon the tolerance of the drug. In addition, 93% of these patients were continued to take UDCA as adjunct drug. They continued the drug, but some people who had some side effect, they were discontinued. So those were 7% of the patient only received ACA, but 93% of the patient received UDCA along with the OCA or either placebo. So the primary endpoint of the study is at 12 weeks, proportion of patient achieving a composite of less than 1. Just before that, let me see. So all entry were the patients who were having alkaline phosphatase levels more than 1.6 times upper limit of the normal, and or bilirubin more than upper limit of the normal, but it has to be less than 2 times the upper limit of the normal. And positive response is taken as a reduction in alkaline phosphatase levels to the less than 1.6 to the upper limit of the normal, and ALP reduction to the more than 15% by the baseline, and bilirubin has to get normalized to the less than upper limit of the normal. And response was found to be rapid, with a significant difference observed between the OCA group and the placebo group by the week 2, and at each point thereafter. So all after 12 months, they were shifted to the open label studies. So you could see this graph. So first 12 months, this is the normal placebo group where they did not find any reduction in the alkaline phosphatase. But once they shifted to OCA, they could see the normalization of the alkaline phosphatase towards the normalcy. And you could find the benefit was seen in both the groups, 5 mg group and also in the 10 mg group. Similarly, you can also see the bilirubin fall in once we start after starting the OCA. And this bilirubin was also seen in both the groups, even though that was slightly marked in the 10 mg group. And also they looked at the immunological marker and inflammatory marker, and they also found some beneficial effect as far as the IgM levels are concerned. And the IgA levels did not show much of variation. IgG levels did not show much of variation. And all the other things did not achieve any statistical significance, but they were shown toward the positive side as far as HSCR, TNF alpha, and IL-2 levels were concerned. When it comes, we are more concerned of the side effects. Discontinuation of drug due to pruritus was seen in 10% of patients in 10 mg group, which is really a bit concerning thing. Whereas only one patient had to stop the drug because of pruritus. And when it comes to treatment emergent adverse events, now which not much of difference between the three groups, and the pruritus and also not significant was found to be higher in 10 mg group compared to the placebo. And serious adverse events, even though it's at higher and slightly higher in 10 mg group, but it was unrelated to the drug. That is, I think we need to keep in mind. And the most common side effect with this drug is the pruritus. And this another study where they looked at also showed this. I think the OCA monotherapy significantly improved alkaline phosphatase levels. If you can see that the reduction is was more marked. This is a study wherein they compared 10 mg with the 50 mg, and they found that the reduction in alkaline phosphatase both in 10 mg and 50 mg group, and also you can see this graph showing the same thing. The reduction was a very significant market in this treated group compared to the placebo. So alkaline phosphatase reduction was observed in this OCA monotherapy study, which is similar to reduction was reported in the previous studies of the UDCA. And here they try to, as I told you, this drug, which through its FXR receptor agonism, has additional effects. These are some of the effects. This is another study where they looked at the histological endpoints, wherein they found that improvement in fibrosis, improvement in bile duct loss, improvement in ductopenia, and also the improvement in interface hepatitis, which was all really very significant improvement in addition to the reduction in ductal reaction and lobular hepatitis. And also they looked at the collagen morphometry assessment, where they found the benefit in all the aspects like collagen area ratio, collagen fiber density, collagen reticulation index, and fibrosis composite score. So we found this found to be definitely beneficial as in PBC patients. Now I'll talk about, and before giving concluding remarks, how it's how does it play? What is going to say in NASH patient? This is we are really more concerned in this way because this forms a major bulk of our treatment patient, and because NASH is going to be a big issue and it's an important game changer as far as the liver disease is concerned. Also, it has a role to play in coronary artery disease, and also it can be #1 player in the liver transplantation. So we are all very concerned. How does the drug play a role in NASH patients? So obetiholic acid in the treatment of NAFLD and mechanism of action, it has a role in gluconeogenesis, it has a role in triglyceride synthesis, it has a role in VLDL, export and fatty acid oxidation and triglyceride clearance. In addition, this patient with high fat diet and obesity and aging, so it has a preventive effect on even on the liver steatosis. So in addition, it has also found to have a role beyond the lipid and corporate metabolism, that is in extracellular matrix remodeling. In vitro studies on human cryopreserved hepatocytes from various healthy donors shown that it has a role in reducing hepatocyte inflammation, reducing oxidative stress. It has a role in apoptosis, in addition to the effect on the TGF-beta signaling pathway. So all these will point to this. It has a role to play in addition in the hepatocyte inflammation and also in the prevention of fibrosis and maybe reversal of fibrosis that we have to see. So, so this is a study on the role of obetiholic acid on insulin sensitivity in patients with NAFLD and type 2 diabetes mellitus. So this has found to have this study was divided into 3 groups: placebo, 25 mg group, and OCA group. They divided into 2 groups: low dose insulin group and high dose insulin group, wherein they found some definite improvement in improving the insulin sensitivity and decreasing the insulin requirement. You can see from this in the see this is positive change has been seen when compared to the placebo, wherein there's not reduction when compared, wherein 28% reduction in 25 mg group and 20% 50 mg group, even though it did not achieve statistical significance. Similar reduction was also improvement in insulin sensitivity was also seen in the high dose insulin group. So based on this study, they found that it has a definite role to play in improving the insulin sensitivity, thereby and improving the blood glucose and glucose homeostasis. In addition, the same study, they also looked at the role of OCA in reducing the liver inflammation and also fibrosis. Here, since it's a very short duration study, it's very difficult to see a clinical change. So what they did is they looked at the enhanced liver fibrosis markers, which include hyaluronic acid, P3, P3NP peptide levels, and TAMP levels. So they looked at, and they found this is additional effect which they looked at in this study. So they found it baseline 85% had mild to moderate liver fibrosis, and all these liver ELF component parameters, which include hyaluronic acid, procollagen 3 amino terminal peptides, and TAMP levels, showed significant reduction when compared to placebo. We need to remember this only biochemical assessment, whether it really transforms into the clinical benefit, which we have to see in the subsequent coming slides in the different studies. So this is one of the important trials as far as NASH is concerned, wherein they studied the effects of receptor ligand obetiholic acid for non-cirrhotic, non-alcoholic steatohepatitis. So wherein they assess the effect of the obetiholic acid in adult patient with NASH, and the treatment was given this patient was studied for 72 weeks. They were divided into 3 groups: obetiholic acid 25 mg and the versus placebo. And the primary endpoint was improvement in the centrally scored liver histology, which is defined as a decrease in NASH score by at least 2 points without worsening fibrosis from baseline to the end of treatment. So this is a slide wherein you can see the primary outcome was improvement in liver histological finding, which required a decrease in 2 or more points in NA score. NA score is mainly you looked at the biopsy score, wherein you see at the hepatocyte ballooning, steatosis, lobar inflammation, portal inflammation. So in this, they found this when compared to the placebo, 50% had a improvement in this histological finding compared to 21%, which was statistically significant. They also looked at the other parameter in addition, NA score. So NA score was found to be 50% reduction compared to 23% in placebo, which was statistically significant. In addition, they also looked at other parameters like fibrosis. You can see the fibrosis improvement was seen in 36% in treated group versus 19%, which was statistically significant. So there was a change in score. So they also looked at individual scores like hepatocyte balloon, which was individually not statistically significant, but when it comes to steatosis, they found statistical improvement, significant improvement in treatment group versus placebo, and lobar inflammation was also statistically significant when compared to the placebo, and portal inflammation did not find much of the difference. So here they looked at the primary endpoint, what they looked and they found to be statistically significant, that is a reduction in NA score by more than 2 points, 2 or more than 2 points. So this is another study subsequent to the first study. This is again a very important study. This is, I think, what the analysis which we are going to show. It's the interim analysis which was done at 18 months with the 2 biopsies, pre-treatment biopsy and the second biopsy which was done at the 18 months, and the analysis was done based on that. So NASH represents an important unmet medical need worldwide, and it's increasing cause of liver morbidity and mortality, and it is anticipated to become the principal indication for liver transplant, as I mentioned before. And currently, there is no FDA drug approved pharmacology therapy for NASH. So this study is going to talk about its role in this NASH patients. So which is the effects or agonist with preclinical activity against NASH. It's a randomized phase to be in the randomized phase 2 Flint study. OCA was given for 72 weeks with the improved fibrosis and other histological parameters in patient with non-cirrhotic NASH. And FDA designated OC as a breakthrough therapy for patients with NASH and liver fibrosis. And as I told you, this is 18 months interim analysis of the randomized phase 3 trial comparing the efficacy of OCA 2 doses versus placebo in patients with NASH and liver fibrosis. So it's a robust study wherein they selected 2,480 patients. They were randomized into 3 equal groups of 1:1:1 fashion: placebo group, OCA 10 mg group, and OCA 25 mg group. Now I'm talking about the 18 months interim analysis with the 2 primary endpoints. One is fibrosis improvement by more than 1 stage with no worsening of NASH, and second is the NASH resolution without worsening of the fibrosis. Success was defined as achievement of either of one of these 2 primary endpoints, either one of them. So this is baseline characteristics for these 3 groups, which is very well matched when it comes to age, gender, fibrosis score, NA score, type 2 diabetes, mean ALT/AST levels, and concomitant medication like lipid-lowering drugs and anti-diabetic medication like thiazolidinediones and vitamin E, which has some effect on NASH. So they were also adequately matched. So at 18 months interim analysis, treatment with OCA 25 milligram met the primary endpoint of improvement in fibrosis with no worsening of NASH in patients with stage F2 or F3 fibrosis. This beneficial was seen across both intent to treat analysis and also the per protocol analysis. So in the intent to treat analysis, this was statistical significant, which was 23% showed improvement in 25 mg group versus placebo, and also similar benefit was also seen in but not very statistical significant in the lower dose group. And even in the per protocol population also, we could see statistical improvement, significant improvement in fibrosis. So this is a robust anti-fibrotic effect of obetiholic acid was dose dependent and consistent across different patient population subgroups. So but the benefit was more marked in the 25 milligram group. And this study did not meet the second endpoint, that is NASH resolution primary endpoint at 18 months. You can see that this was not much of a difference between the 3 different groups in both intent to treat analysis and also the per protocol analysis. So primary endpoint, first one was met in the reduction of fibrosis, but NASH resolution was not met. But they did some post hoc analysis of this with this data, wherein they found that 25 milligram patients had twice as many achieved NASH resolution compared to the placebo. This is only a post hoc analysis, wherein they found statistically significant improvement, wherein 25% showed achieved NASH resolution compared to 11%. When it comes to this improvement of fibrosis of more than stage 1 compared with placebo, so in this 25 milligram group, wherein that 38% showed improvement compared to 13%, whereas in the placebo you can see 21%, 23%. So that means almost like 3 times more number of patients showed an improvement in fibrosis score by more than 1, and whereas this was not observed in the placebo group. And also there was some improvement in 10 mg group also, but it was more marked in the patient who received 25 mg. This again a per protocol analysis. And again, this is a per protocol analysis and the intent treat analysis of this patient who received. See, I'll come to the point wherein I think we have. See, when it comes to improvement, as I discussed already, improvement in fibrosis by more than 1 stage was definitely statistically significant, which is you can see from this slide. And the other thing where we found some other improvement is also the improvement in fibrosis more than 2 stages. This we found in only in the per protocol analysis, but not in the intent to treat analysis. Whereas fibrosis score by more than one stage was seen in both the groups. But whereas subsequent analysis and per protocol, we found some improvement more than in fibrosis by more than 2 stages in the 25 milligram group. And they also looked at the histological improvements like lobular inflammation, hepatocellular ballooning. So this is again per protocol analysis. They found this improvement, and this improvement was seen when in 44% of patients when compared to the placebo, which was statistically significant. And also they found improvement when they did a pathological assessment of NASH resolution with no worsening of fibrosis. In the per protocol analysis, they also found a statistically significant improvement. So features of steatohepatitis such as hepatocellular ballooning as predictive of increased liver cell events and reduced transplant survival. So these are some of the improvement which we found with this drug in 25 milligram group, and then subsequent per protocol analysis, but not in the intent to treat analysis. So OCA treatment also resulted in a dose-dependent improvement in markers of liver injury, that is ALT and AST levels, and also the oxidative stress. You can see from this graph that you can see improvement in ALT levels, AST levels, and also GGT levels, but somehow this did not show that great improvement in alkaline phosphatase levels. So when it comes to this adverse events, and first I'll talk about the discontinuation of the drug. This is very important. I think I want to highlight here. In 25 milligram milligram group, 13% had to that is 13%, which is a very huge number, had to discontinue the drug because of the side effect pruritus, whereas which was compared to 6% in placebo group. When it comes to the mild, moderate, severe, and also again you can see that it was 20%, 24%, which is not much of different, 51% versus 45%, not much of different. When it comes to severe side pruritus, it was 20% or 13%. So can be a problem in high dose group when it comes to the side effect like pruritus. And other, this I'm talking about the overall severe side effects. But when it comes to the pruritus, I think grade 3 was in 5% when compared to less than 1%. This I think we need to highlight. So this is a very important side effect with this drug. When compared to other side effects, I think not much when compared to the placebo group. And again, it has, as I told, it has some effect on the dyslipidemia. Some are beneficial, some can be transient, something like increasing LDL levels, decreasing HDL levels. But again, most of these levels were found to be transient, which were really could overcome with the prolonged usage. So let me come to the conclusions. It's this REGENERATE study. It's a randomized phase 3 trial which met FDA criteria for success with OCA 25 milligram versus the placebo, meeting one of the two primary endpoints as at interim analysis. That is, a primary endpoint of fibrosis improvement by more than one stage without NASH worsening was met. NASH resolution without fibrosis was not met, but post-hoc analysis showed improvement in steatohepatitis. And also OCA was associated with improvement of fibrosis staging, NS scores, ALT, AST, and GGT levels with not much of change in alkaline phosphatase levels. And adverse events mainly mild to moderate, consistent with OCA safety profile. And pruritus was a significant side effect, but life-threatening side effects and was found to be comparable to the placebo. And investigators concluded that REGENERATE study represents first successful phase 3 trial in patients with NASH, and study is ongoing to confirm the clinical outcomes. So this is the data which I wanted to bring, because clearly what is the data we have so far when it comes to OCA in both PBC group and also the NASH group. So PBC, I think we found a definite improvement and is also FDA approved. But when it comes to the NASH, I think so far the data whatever we have, we could clearly see some biochemical blood parameter and histopathological improvements. But whether this will really translate into the clinical benefit, something like total reversal of NASH and total reversal of fibrosis, that we have to see. So I think we need more randomized long-term studies, even though we found some definite beneficial effect with this OCA in this NASH group, but still we remain to be, I think, should be very skeptical. Still we get a complete data. And also, not to forget, there are some side effects like pruritus with this drug. And should we not use this drug till we get long-term data? I think I would not say that not to use in none of the patient, but yes, select a subpopulation wherein I think you see by any time if you did a liver biopsy wherein you saw some F2, F3 fibrosis and with underlying diabetes and dyslipidemia. Definitely you can see some improvement in this patient in prevention, progression of F2, F3 to the cirrhosis. But pure NASH patients, early fibrosis, where should be used, I think I think we should wait and see. So what is my personally feel, I think till we get some more data, I think you can select patient, really super select the patient for using this drug. And also not to forget this disease, what we're talking about, the metabolic syndrome and NASH, is a multi-factor disease. It's not just only one factor which plays a role here. So we also need to highlight other things like obesity plays a role, sedentary lifestyle plays a role, diabetes plays a role, dyslipidemia plays a role. So all these things also simultaneously need to be addressed. Even though drug has great effect, but still I think we should wait for some more trials before really conclude and definitely decide that this is going to be the drug for NASH. So with this, I'll conclude, and thanks all of you for your patient listening, and also the Mylan group for giving me this opportunity to deliver this talk. And I'm ready and welcome any questions on this topic.
Thank you, Dr. Sriveni, for the excellent talk. So we will take the first question. First question we have from Dr. Ajit Purnia, Bihar.
Can I exit this presentation?
Yeah, just a minute, Mr. Dilip. Yeah, doctor, please press escape and come back to browser. Google Chrome.
Stop share.
Yes, and click on stop screen. Perfect. You can begin, Mr. Dilip.
Yeah. Sir, Dr. Ajit has asked a question from Bihar. He has stated like he has a patient with a bilirubin level of 5.7, and even the SGPT level is also very high with 550 reading. He has asked a question like, shall we give obetiholic acid or a UDCA? Please suggest me.
What is the disease you're talking about? Is it a PBC or NASH-related cirrhosis? What is it? What's the disease? If it's a PBC, yes, definitely. I think you can combine both the UDCA with OCA because the side effect profile is not going to get worsened by combining both these drugs. Definitely, you are going to get some add-on benefit because it's a hydrophilic bile acid UDCA. It definitely has a role to play, and in addition, you can use obetiholic acid. I think there is no doubt as far as PBC is concerned in this patient. Definitely, don't delay it. I think it's definitely you can get a fruitful outcome in this drug in retarding the progression of the disease.
Thank you, sir. So next question we have from Dr. Ramesh. He has asked like, how long do you recommend OCA, and what is the ideal dosage to start with?
Well, again, we need to have, I think I would say there's some more studies to say. I think better start with the lowest dose. See here, I think what we should see is we don't have adequate experience. Start with the low dose. Look for side effect profile, because that's how we did in the initial trials, where they started with 5 mg and 10 mg, but their tolerance was more in the 5 mg group. Once they tolerated very well, then they shifted to the 10 mg. So that's what even I would suggest. If really a drug is required to be given, start with 5 mg, closely address, look at the side effects. If they're tolerating it well, maybe then you can increase it to 10 mg. And going beyond 10 mg, I would not suggest now. Still, we get some more studies, and also we don't have Indian data. So 5 mg would be, I think, reasonably good bet to start.
Okay, sir. So there's next question is from Dr. Dipti. She has asked Dr. Saraglitazar versus OCA, how to position these drugs. Can we use both the drug at the same time?
I don't have any personal experience, but as far as looking at this pattern of beneficial effect, I think you can combine it. There's no harm in combining it, but I really don't have any experience. But based on whatever, looking at the way pathophysiological effect of and also the physiological functioning of both these drugs found to be different. So maybe you can get a complementary beneficial effect, but you closely watch for the side effects.
Yes, sir. Sir, Doctor, next question is from Dr. S.M. Manjunath. He has asked, OCA is having pleiotropic effects in the multiple organ. Which are all the things we need to check, because it is mainly reducing HDL level and high percentage of pruritus is also observed. How this can be managed?
So sorry, can you repeat the question once again? So it has
Yes,
a
sir.
pleiotropic. Yes, that's true.
Yes, sir. And what are the things we need to check, because it is reducing HDL level and the high percentage of the pruritus is also observed? How it can be managed?
So see, most of these effects, like more marked reduction was seen in the triglyceride, but again they started. It's a good thing, but again they started having upward trend and become normalized. And when it comes to the HDL, also it has a scavenger effect on the receptor pathway. But again, all these effects were found to be transient. I don't think this is going to worsen any worsening effect on atherosclerosis. As far as that is concerned, our main concern is worsening of the dyslipidemia resulting in worsening of atherosclerosis. So far, this has not been found in any of these studies. So more, I think I would say most of these effects on dyslipidemia are all transient. So that we should not much worry about.
Yes, sir. So Dr. Kirti wanted your view from Nalgonda. The patients currently who are using saroglitazar can be shifted to CA.
Well, it's your personal choice. Are they improving on saroglitazar? If they are not improving, my suggestion is either you can do some liver biopsy or some kind of a scoring where if you can find them F2 or F3 fibrosis. I think the progression from NASH to F0, F1 fibrosis is slow when compared to progression from F2, F3 to cirrhosis. So identify a subgroup of patients who are having F2, F3 fibrosis, which you can do non-invasive fibrosis markers, or you can do any transient elastography, identify the group. If you find them really having advanced fibrosis, yes, definitely you can consider giving this drug. So far, I think my personal opinion is identify patients who are having advanced fibrosis, wherein really you want to prevent them progressing to the cirrhosis.
Thank you, sir. That's the end of the questions, actually. Sir, we really appreciate your time and effort, sir, and in letting us with all the aspect of the molecule, whether it is medical study, trial, safety, usage, about the obetiholic. This is a today's hot topic, because we don't have much of treatment options for the NASH, and definitely with the views of yours and many doctors taking up going forward, this is going to be a good treatment options for the patients who are been deprived from a long time. And I'm sure even the attendees are very delighted and elated with your talk, sir.
Thank you.
And finally, sir, I would like to thank all the participants and the doctors from all India, sir, who have taken out the time from their busy schedule and attended this thought-provoking session from Dr. Shrivenu. And sir, on the behalf of Mylan, I again take this opportunity to thank you, and it was an honor to have you in this session, sir, and giving us a clarity on the molecule, sir.
Thank you so much. Thank you, Mylan bro. Thank you, Dilip. And
thank you, sir, and happy
thank you,
Independence
others.
Day to you and all, sir.